Today, trauma. Trauma, gun and knife club, car accidents, falls, all of that pretty much splits into two groups: blunt, penetrating. This topic is pretty much for the emergency room physician, resident, general surgery resident, medical students. If you are a layperson and you're trying to learn about penetrating and blunt trauma, you got issues or something else is going on, and this is probably not the place you need to be. You need to talk to somebody else about your issues, or if you're planning stuff, again, local, whoever, police officer, somebody, counselor, your mom, your dad, call them. But this is really just for people who are doing trauma and taking care of trauma patients. Now, when you're dealing with a trauma patient, it always starts with one topic and one topic only. Before you get to whether it's blunt or penetrating, you want to make sure the patient is stable. It doesn't matter if they are penetrating or blunt. If they're unstable, traditionally those patients go straight to the emergency room, straight to the operating room, unless there is something else going on that attributes to their instability. So, trauma, the first thing you look at, A, B, C, D, E. Airway, breathing, circulation, disability, and environmental stuff. So airway means make sure that there's nothing blocking your airway. Make sure there's not a foreign body in there. There's making sure that your tongue is not swelling, whatever. Breathing, usually that means intubation, but making sure that you're taking good respiratory breaths, making sure that you're doing effective oxygen exchange, making sure that you can breathe. C, circulation. Make sure your blood is flowing enough. Make sure that your heart is beating to get blood flow to your extremities, to your brain, to be able to perfuse with the oxygenated blood that's coming through your airway. So that's why it's A, B, C in that order. Because if you don't have air to breathe, it doesn't matter about your circulation. D, disability. That's more of an assessment of why you're having problems with your circulation, breathing, or airway once you get these pseudo-stabilized. Environment means, again, making sure why any of this occurs. Is there any extenuating circumstance? So anytime we talk about trauma, you'll say it's a 14-year-old Asian male presents with gunshot wound to the chest. On arrival, air A, B, and C is intact. Primary survey, blood pressure is this. So that tells us the vitals, whether the A, B, C, D's, and E's are all together. And then you start looking at the rest of the history and physical. So then you start asking what happened. You then start saying, I was in a car accident, I wasn't wearing my seatbelt, got shot, got stabbed, girlfriend stabbed me, boyfriend stabbed me, somebody stabbed me, my ex-wife stabbed me, a lot of stabbings, or a mother-in-law shot you or ran over you with her car, whatever. That's when this comes in. But you don't really worry about your history and physical as much until you have airway, breathing, circulation, D and E taken care of. Again, stable versus unstable. Stable, you have time to go through other stuff. If unstable, usually that means direct trip to the operating room. Now, blunt versus penetrating. If you're a surgery resident, we call that not fun versus fun. The reason blunt is not fun is because most of those patients don't require operating room treatment, or there's no fun surgery with it if you're a resident. If you're attending, none of it's fun. But there's no procedure that is usually done. These patients, observation, treating them symptomatically, figuring out what's wrong with them, consulting the appropriate person, doing the appropriate test. Penetrating, that's when the fun starts. So we're going to start with the boring stuff first. With blunt trauma, you have contusion, abrasion, laceration, fracture. So basically, if something gets crushed, if something gets rubbed off like road rash. If you're on a motorcycle accident, you fall off, skid a mile down the road, abrasions. Lacerations, cuts from glass, from going through a pane glass window if you're high on drugs. Anything that causes a superficial laceration, that actually falls into blunt trauma because there's blunt force that tore the skin. Fractures, orthopedic surgery consults, hip fractures, femur fractures, tib fib fractures, finger fractures. Once you get out of these categories, then that tells you what you need to focus on. For the purpose of the most common stuff seen in emergency room with contusions, we're going to talk about car accidents, okay? Now that also includes if you fall off a ladder, if you have a 2-story fall, 3-story fall, the mechanism is different, but the overall assessment and treatment is still going to be the same. If you fall, car accident, whatever, any type of blunt trauma to a body, the first thing that you worry about injuring is the liver. The second thing is the spleen. The third thing, intestines. Intestines, spleens, and livers are traditionally injured by what we call deceleration injuries. So you're going along 60 miles an hour and then you run into a brick wall. When you stop, the liver and the spleen will keep going. So then they rupture up against either the rib cage, because you think about it, the liver and the spleen are essentially covered about 2/3 by the ribs. So that acceleration, deceleration causes injury. You can also have brain injuries, and we'll get about loss of consciousness down here, but it's another organ that has an acceleration, deceleration component because it's surrounded by a bony structure. It can also be external if you have something like a seat belt in a car. So specifically with cars, when you're in a car accident, and if you see one driving down the street, the first thing that someone always does is put their neck in a collar, because you have to assume that there is a cervical spine injury until you can assess whether there isn't one. Now, a trained general surgeon, who is also a trauma surgeon, same thing, or an emergency room physician can assess whether someone has an injury. For the most part, if they have full range of motion without pain, up, down, left, right, look up, turn left, turn right, without any injury, without any pain when they do that, and they can hold their head up, the majority of time they do not have a cervical spine injury. If they don't have a neurological deficit, they more than likely do not have a cervical spine injury that's significant that requires surgery. Now, if they turn up, left, down, right, and they say, well, it's a little sore, assume that they have an injury, and you're going to have to do an X-ray, cervical spine series, or a CT. If it's not completely normal, you have to assume there's an injury, because if you have an unstable cervical neck injury and you don't protect your spine, they can become a quadriplegic because you didn't do the stuff necessary. I've seen plenty of patients getting injuries in necks in accidents that I didn't assume were going to be significant, but when you get in there, they actually have a C1 or C2 fracture and they have to go straight to surgery. The speed of the car accident or the mechanism makes a significant difference. If someone's in a 15-mile-an-hour car accident, they're probably not going to injure anything. If they're in a 20 to 25 and they're not wearing a seat belt, there's a chance that they could hit their head on the steering wheel. They could get their head on the glass. They could get a concussion from the airbag deployment. So speed is important in assessing these injuries. If it's a head-on collision, you're looking for one thing, versus a T-bone injury, you're looking for something else. If they flipped a car, you're looking for femur fractures. If you're one of those people that likes to ride with your feet up in the window and you get a car accident, those are the kids that get amputations of their legs early because they're riding around with their feet up, and as soon as they get in a car accident, their femur snaps because the dashboard comes through. Some of this is gruesome, but it is what it is. Now, car accident, 23 restrained passenger MVA. You got to know whether they're driving or they're a passenger, because again, it's stuff like if you're driving In the United States, the seatbelt goes from your left to your right. If you're a passenger, it goes from your right to your left. So you're looking at different sides of the chest. Most trauma assessments for blunt always start with a chest x-ray. If it's a car accident, you get a chest x-ray and a pelvis film in the trauma bay. Once that is done and those are cleared, you then do an assessment of the cervical spine, rock their pelvis, and do what's called a FAST. We'll get over the FAST over here, but that's essentially an ultrasound of the abdomen as well as the chest, looking for fluid in spaces that are not supposed to be there. Ultrasound is probably the biggest advancement. Shout out to Grace Rizicki, MD, Emory University, that's where I went. But ultrasound is probably the biggest advancement in trauma assessment in the last 10, 15 years, because it allows us to look at someone within 1 to 2 minutes of them coming in and having a good idea of what we're dealing with. So FAST, and we'll go over it with it in penetrating, it really belongs in blunt, and that's really where it came from. But for some reason or other, it's kind of migrated into penetrating trauma. So we'll just write that up here. Just remember FAST, which is basically ultrasound. And somebody added an E to it. Now, falls. The other thing that that happens all the time to people fall out, pass out somewhere. Ground level falls do not require an emergency room visit unless someone passed out. If you fall down and hit your head and you don't pass out, don't worry about it. You can go if you're worried because you have neurological symptoms, but for the most part, if you go to the emergency room, ground level fall, head CT is negative because you may or may not have passed out, we'll send you home. If it's higher than a ground level fall, then we may do more testing or you may undergo observation. But just because you fell and hit your head, it's not that big of a deal, because evolutionarily, people have been falling all the time. If your head was so fragile that you would fall and get a brain bleed, people would not exist. We've been hitting our heads without helmets for I don't know how many years before, when we were cavemen chasing everything. So evolution, from an evolutionary standpoint, a ground level fall, we're okay. You fall out of a tree, that's a different issue. You're on blood thinners, Plavix, aspirin, Xarelto, anything else, that's a completely different issue. Ground level fall, not as worried. Loss of consciousness, that's the determining factor as to whether someone gets a CT scan or not with a ground level fall. Neurological exam, if it's abnormal, CT scan. If it looks questionable, admit observation. X-rays are good for looking at C-spine, T-spine, L-spine series. For X-rays, CTs, anything in blunt trauma, fractures, lacerations, abrasions, whatever, we always ask, does this hurt? We do a good physical exam, and if it hurts, you X-ray it, because again, bones get fractured all the time in blunt trauma. So that pretty much covers it. But the interesting thing is that I didn't talk about any surgeries for any of these issues, because the majority of them for blunt trauma do not require any surgical treatment. It's usually observation, supportive care. Now, yes, if you injure your spleen and you have a grade 3 or grade 4, then your spleen is coming out. Grade 1 and 2, we watch. Liver lacerations, grade 1 and 2, we watch. 3, we consider embolization. 4, you may require surgery, but it's packing and reoperating to make sure that we can control the bleeding. But those patients are hypotensive and go directly to the operating room. All of these things, people make their careers on just talking about blunt trauma. But again, this is an overview. So from a blunt trauma standpoint, someone comes in, car accident, are they driver, passenger, know the mechanism of the injury, airway, breathing, circulation, and then ask them where they hurt, and then go from there. And then your workup will determine what you do to them. Now, penetrating, stabbing, shots, whatever, completely different topic. Let's talk about it. Penetrating trauma, stab wounds, gunshot wounds. Now, when a tree goes through somebody's arm, that is technically a stab wound. Doesn't sound like it, but it is, because the mechanism is the same. If you have a small projectile, whether it's a BB, 410, 223, 243, 270, 308, NATO round, whatever, gunshot wounds. The most common place to get stabbed is the abdomen or chest, and that's usually because it's the biggest target on someone. If you are looking at gunshots, as crazy as it sounds, it's usually the extremities first. People always get shot in the leg or the arm. So a lot of the gunshot wounds that come to the emergency room are extremities, and they don't require surgery. After that, it's chest. People are trying to shoot you in the chest, center mass. The majority of gunshot wounds to the chest require a chest tube, but not a thoracotomy where we're looking in the chest. Interestingly enough, stab wounds usually require surgery more often than gunshot wounds, because we have to determine whether they penetrated any or through the abdominal wall into any organs, and that sometimes requires surgery. Chest stab wounds, because it's a slow velocity projectile in and out, or sometimes just in and never out, those patients require chest tubes and can bleed a little bit more than gunshot wounds. So gunshot wounds, stab wounds are a bigger pain in the butt from a surgical standpoint, because I have to do surgery to figure out where they went. Now, gunshots are only really a pain in the butt if they're a great shot. If you hit them in the chest, if you in the heart, if you hit them in the artery, if you hit them in the abdomen and it actually goes in the abdomen, then that's a whole different issue. The nice part about stab wounds are straightforward. So it's usually a linear thing. So if you stab Deku, sorry, Deku, was Goku last month. If you stab Deku here, and it goes this direction, it's gonna end up there. Now, if it's a gunshot wound, as crazy as it sounds, you can shoot Deku here. It can bounce off of his rib and go here. It can then bounce off of his pelvis, go here, and get stuck right here. So you would think that the trajectory is straight, but because of these bony areas, it's not. So gunshot wounds are very tricky. So you kind of have to have a pretty good story, CT scan, that makes you believe that it goes straight. If it doesn't, you got to take them to the operating room sometimes to explore them. I've had people that have gotten shot in the chest and it ends up over here, and it's gone through the aorta over here and then gone down. There's bullets just kind of do weird stuff. Now, penetrating trauma is still the same: airway, breathing, circulation, diagnostic imaging labs, but usually if these patients are unstable, they are more likely to be unstable with penetrating versus stable with blunt. We take them to the operating room. Indications for laparotomy, I'm going to put in here oscopy. And this is going to cause some issues because it's technically not ideal, but it's a good idea. And I'll tell you why. So laparotomy is the standard for something that you can't figure out where it went, how it went, why it went. In that situation, you take them to the operating room, open their chest or open their abdomen to find out what's going on, especially if they're unstable or the mechanism does not match the injury. I like oscopy for stab wounds to make sure that they penetrated the abdomen, because a lot of times people get stabbed and they'll stab up and they just go into subcutaneous tissue and don't go into the abdomen. If they go up and don't go into the abdominal cavity, there's nothing else to do. So this oscopy, or sticking a small camera in like you're doing a gallbladder, saves them a big midline incision. If you find something that's positive or you find blood in the abdomen, you convert the laparoscopy to a laparotomy. In the hands of a good laparoscopist, this only adds 1 to 2 minutes to the procedure. Again, if the patient is unstable, you skip this part and go straight to a laparotomy. Gunshot wounds and laparoscopy usually don't mix well, with the exception of if you're trying to figure out if the bullet actually went through an organ. Except in certain situations, if you have a good trajectory and you don't think that trajectory actually is in the abdominal cavity, you could consider it then. But you have to be careful with using laparoscopy with gunshots. Now, hemodynamically unstable, those patients need to go to the operating room. There's no question. Doesn't matter. If they're hemodynamically unstable, they need a laparotomy, sometimes a thoracotomy. In trauma, we sometimes call it the Texas T. The Texas T is where you actually go down. So you do exploratory laparotomy, and then you have to do a thoracotomy, a clamshell at the same time. I don't know why they call it a Texas T, but we call it a Texas T. Stuck on something, those patients need to go get the item removed as well as fix any holes that were caused. Evisceration, that means you have intestine falling out. You'll have patients that come to the emergency room with intestine hanging out. Those patients got to go to the operating room. There's no reason to even pretend like they're not going to the operating room. They have to go because you got to put the intestine back where it's supposed to be. So yes, as soon as you see a patient come in the emergency room with intestine hanging out, call the surgeons. Don't say, oh, we'll put a wet, dry dressing on and send them upstairs. They're going to the operating room. Penetration of the peritoneum or the retroperitoneum is an indication for surgery. Now, whether that surgery is to confirm with laparoscopy or fix whatever organ has been injured under laparotomy, or if you're unsure if anything was injured or not and you want to take a very good look because of the mechanism, exploratory laparotomy. It's a great indication. All of this is done to save someone's life. If you can't say with 90% certainty that their life is not at risk, then you need to consider exploring that cavity. Fast, evaluate for fluid in a space. Originally, it should not be in penetrating. It is specifically designed and studied originally for blunt trauma. It gives you good information for penetrating, but it is not designed for penetrating. It is truly for blunt. Now, because it's taken off so much, a lot of emergency rooms use ultrasound for penetrating trauma. And ultrasonic, it's basically focused assessment, sonographic evaluation of a trauma patient. What that means is we're looking at a couple different spaces in a patient. The first space is right here by the heart. What you want to do is make sure someone doesn't have cardiac tamponade, so they have blood around their heart and it can't work. You also get some idea as to whether or not they have fluid in their chest. But again, these patients are getting chest x-rays as soon as they walk in, and that'll tell us if they have a pneumothorax or a hemothorax. The next one is the hepatorenal space. Basically, that's the space between the liver and the kidney on this side. If you have blood in the abdomen, it's going to pull up on this side, and you can see that very well with sonogram. The next one is a splenorenal on the other side. Again, liver, spleen, most commonly injured organs, so it makes sense. Because they're posterior and they occupy space and you kind of have this area that can accumulate blood, again, a good space to look to see if there's blood in these areas. Last one is deep in the pelvis, and you want to see if there's any blood down here. This is sometimes a hard window to get if the bladder is not full, but if your bladder looks like a can, that can also, as opposed to being flat and round, that also means that you may have bleeding from your pelvis, which is injured, again, in blunt trauma, not so much in penetrating, but you can see blood running down if they're penetrating. It's a good assessment. So if 1 or 2 or 3 or any of these are positive, that requires emergency surgery. The only time that's an issue is here. If you have a little bit of blood in here and you think it's physiologic fluid and not blood, sometimes we'll repeat that 5 minutes later, 2 minutes later, watching the patient closely. Or what we used to do at Grady is take them actually up to the operating room because we had about a 2 or 3 minute trip. And then we would reassess them again with the ultrasound upstairs before we proceeded with surgery. So yes, this is a blunt technique that has been adopted by penetrating, but it really just looks for fluid in spaces. Now, antibiotics, yes, come in because most of this stuff is dirty, or if they get shot through with jeans on, there's a chance that you can pull jean material out of the gunshot wound. Prophylactic antibiotics are always a good idea for any type of penetrating trauma. If they have anticoagulants, you need to reverse it. Used to be was just Coumadin that we worried about. Now between Plavix, Xarelto, Eliquis, all these other medicines, that's become a little more challenging, but most agents that you have to anticoagulate someone, we also have a medicine to reverse that. And the majority of that is for trauma. One thing that goes with penetrating and blunt, because we use so much anticoagulation right now, anytime someone has some type of anticoagulant on board, for me, I admit them to the hospital just because you never know what's going to happen if they are bleeding a little more than normal. The majority of information about penetrating and blunt trauma is not based on patients that have been anticoagulated. So you have to have a second layer of suspicion with them. So if they have a head injury, loss of consciousness, and they're on a blood thinner, I would admit them. Even if they weren't on a blood thinner, I wouldn't. But in that situation, that blood thinner makes me say, okay, something else could happen. So I admit those patients. Pretty much that's an overview of trauma, blunt versus penetrating, car accident versus stab wounds. Car accidents, usually managing the problems that they have, consulting orthopedists, consulting neurologists. Penetrating, making sure they're not dying. If they are dying, take them to the operating room, save their life, and then get everything else treated. The one thing that you got to remember with trauma patients is that saving the life is the main priority. It's not doing a lot of fancy tests. It's not doing a lot of discussion. I've had patients that they had family members that wanted to transfer them to different facilities. I told them, no, they're not going anywhere. They're mine until I save their life and stabilize them. Sometimes the families don't like that. But again, my job is to take care of the patient first. So trauma can get a little tense. It's really not like it is on television, but it is absolutely necessary. Hope this gives you a pretty good overview. Remember, airway, breathing, circulation. If you have any questions, DM me, Instagram, send me a message. We'll get them answered. Hope this answers everything. Take care.
Ain't nothing wrong with thunder with the rain.